So this next case, I want to give a shout out to one of our just graduated residents, Dr. Laura Chan. Our residents really held down the clinic during these COVID times. They were like on the front lines, seeing the emergency patients. And so this was one of the patients she saw, and then she, kind of shot me an image and was like, hey, what do you think's going on here? So I want to give her a special shout out for these cases. My protege, really proud of our residents that have just graduated here. So this particular case, proliferative, that is the question. And so this was a 50-year-old American Indian male. He just complained of generalized decreased vision in both eyes. He was previously diagnosed with severe non-proliferative disease back 2 years ago. He's had type 2 diabetes for 11 years. And you may think an A1C of 11.8 is bad, but this was actually an improvement from 13% for him. He also has some sleep apnea, hypertension, some other risk factors for diabetic retinopathy and progression. His best corrected vision, 20/20. And what we can visualize here on his Claris imaging over on the left-hand side, this ultra wide field, right? He has some dot plot hemorrhages, almost looks like some flame hemorrhages too, right? So we probably also have some hypertensive retinopathy. There's a lot of areas of retinal infarction, or these kind of large cotton wool spot type lesions that help clue you in that there's probably a lot of retinal ischemia or infarction that we're going to see on OCT angiography coming up here. There's no obvious neovascularization to me, right? There's something on the disc that kind of looks funky. So, there's definitely something on the fundus exam I would flag and say, I need to get an angio scan of the optic nerve head, a 4.5 millimeter cube, to visualize this in higher detail to see if that's neovascularization of the disc or not.
And as we are seeing more of these patients, we are realizing the posterior pole, the old myth that diabetic retinopathy for type 2 is only going to be in posterior pole, is being challenged, because as we are imaging wide and wide, you realize a lot of these patients actually have peripheral, mid-peripheral and peripheral pathology, which the conventional thinking is only present in kind of more of type 1.
A lot of times when I see that there's like these predominant peripheral retinopathy lesions, I'm more likely to think, oh, there's some sort of carotid issue. But I'd say probably only like 1 out of 10 actually comes back with significant stenosis that maybe explains it. So I think the rest of those patients where it's predominantly peripheral diabetic retinopathy, it just signifies to you that, hey, this really is a thing, and this patient's more likely to progress, which I'm going to cover in a case here later on. But when you have predominantly peripheral diabetic retinopathy, you got to watch those patients more closely. I put the follow-up a little bit tighter, knowing that they're at increased risk. So here on the OCT angiography montage, we can appreciate that there's definitely this non-perfusion in the periphery that we kind of expected based on a lot of the cotton wool spot and retinal infarction that we saw on the color fundus photograph. But look like down in this area where there's like this very large area of capillary non-perfusion, if we look over at the retina, there's nothing white, so this isn't any sort of acute infarction. This must have been some past infarction that had occurred in the retina. And OCT angiography is making that visible to us, while, just looking at the fundus, we can't visualize that with fundoscopy alone. And we can start to see that there is, in fact, some irregular vascularization on the disc. We'll look at that in higher detail here with our 4.5 millimeter optic nerve head angio scan. And so remember we said the vitreoretinal interface is going to help isolate out neovascularization for you. And so on the vitreoretinal interface map, we can see that there are some fairly smallish areas of neovascularization of the disc. We can see this fibrous tissue kind of hanging across the cup. It has some red overlay on it, which means this is actually vascular tissue. This isn't just some sort of regressed fibrous type of tissue. What I think is surprising is that like this area here to me, it kind of looks like fibrous. I don't really see any obvious neovascularization on the disc, but then there's like a very large area of neovascularization there that just really isn't easily visible unless you do OCT angiography.
These are the patients you had to wait for staining of the angiogram for the really late phase pictures to even find it. So it's so amazing you can see them non-invasively now.
And much faster, right? So you don't have to take images that say like 5-7 minutes to look for late leakage on fluorescent angiography. We're able to just get it in a few seconds, taking a OCT shot. On his macular scan, consistent with his 20/20 vision, he doesn't have any central involved macular edema, which is great, but he's still definitely got a problem, which is high-risk proliferative diabetic retinopathy. So I would have graded the neovascularization on the disc probably like 1/3 to 1/4 disc area in size, which is the definition of high-risk proliferation. And so he falls in this bucket again where probably PRP or anti-VEGF would be recommended for this patient.
And I agree. I think first turnaround in this kind of a patient where the macula is relatively spared is to hit those areas of non-perfusion and make sure we decrease the VEGF production to prevent them from getting macular edema.
You absolutely nailed it, right? This is the guy who's 20/20. We got to keep him 20/20. I completely agree with you.